So the month of July has been set aside to bring about awareness for juvenile idiopathic arthritis.
How different is juvenile arthritis from what adults suffer?
So in adults, commonly you would have what we call osteoarthritis, which simply put would be sort of wear and tear of the joint over time, right? Then some adults would also have septic arthritis, which is less common compared to children. Then other adults can also have rheumatoid arthritis, which means your body reacting against itself and specifically the joints. So all these three types and others can happen in adults. For children, commonly we would have the juvenile idiopathic arthritis, right? Which is less common compared to the septic arthritis.
Okay.
So
the septic is what is you say it's caused by infections. Okay.
Yes, infection. So for adults, I think we have a larger spectrum of conditions that can cause arthritis. Children, commonly to be the septic arthritis, and then we have to a lesser extent our juvenile idiopathic arthritis.
If a parent has a child or a guardian has a ward who is constantly complaining of pains in their joints, can that amount to arthritis? And what signs can any parent or guardian look out for?
So limiting it to juvenile idiopathic arthritis, because for septic arthritis, let me make a comment on that. It's fairly common, and our care providers fairly skilled at diagnosing it compared to juvenile idiopathic arthritis. And the symptoms are so profound that you cannot miss it. Severe pain, pain that doesn't remit, so you'll be forced to see a doctor. But for juvenile idiopathic arthritis, the presentation may be very, very subtle. And commonly, you could have just morning stiffness without pain. A child who normally would like to ride his bicycle in the afternoons or in the mornings just stops riding. Or you notice your child limping without any complaint of pain. Or you notice a swollen joint, no complaint of pain. The teacher could notice that the child will write for some time and just drop the pen and refuse to write. So the presentation is fairly broad, and it could be very, very subtle, or you could have it very overt, where you have joint pains, child complaining of swelling, refusal to move, and all of that. So that's what makes the diagnosis a bit difficult. That for the subtle symptoms, you need to be very observant as a caregiver or a parent or even a teacher to pick up these signs. Yes, then escalate it further to a healthcare provider.
Are there factors that make children prone to juvenile arthritis?
So for juvenile idiopathic arthritis, like the name says, idiopathic, so we don't know. But what we know is there could be a genetic likelihood that you may develop it. Then there could be things in the environment that could also turn on this likelihood. So some viral infections and all. It's commoner in females. And if in your family there's a history of what we call autoimmune diseases, that's your body reacting against itself, then you may have a slightly higher chance compared to other people. So these are what we call the risk factors for developing, but for the cause itself.
How do you diagnose this?
So the diagnosis is what we would call clinical, meaning that, first of all, meaning that there's no particular laboratory examination that would help us to certainly diagnose this condition. So, for example, you do test A and say that once test A is positive, then you have this juvenile idiopathic arthritis. So we'll put things together. We'll put the history together. You're having joint pains lasting for more than 6 weeks, a child less than 16 years. Then we try and make sure all the other possible causes of arthritis have been ruled out. Then we can comfortably say that, yes, we are most likely dealing with juvenile idiopathic arthritis. So it's putting the history together, your examination together, and a few laboratory examinations together, then the diagnosis is made. So it presents a challenge for some primary health doctors because there isn't one particular examination or test, you can say that yes, once this is there, you have your juvenile idiopathic arthritis.
So in the month of July, what do you do? So for children, do you, whenever a child comes into a health facility, do you go ahead and do tests to look out for juvenile arthritis?
So our drive in the awareness on juvenile idiopathic arthritis is to first start with education of all stakeholders, parents, caregivers, teachers. Know the signs, know that there's a very wide spectrum of presentations. So it could be very subtle, joint pains, limping, refusal to do their usual activities, or there could be very clear-cut signs. And then early reporting, so stressing on the early reporting. So once you pick these things up, report early. Then we'll go through the full list of the possible conditions of joint pain and swelling. And once we go through our list, if it fits our criteria or our set of rules for juvenile idiopathic arthritis, we'll make that diagnosis, then advise on the management. But once we pick it up early, there's usually a very good outcome.
So you say you pick up on management. It means it's not treatable.
Yes, I would like to use the word management because typically the cause of this condition, we describe it as, we use the words remissions and flare-ups, meaning that there are periods where there are no symptoms, child is fine, can run around, play, do everything. Then there are periods when you have the pain, the swelling, the stiffness and all. So
does it mimic autoimmune diseases?
So by and large, it falls under the category of autoimmune diseases.
Okay.
Yes, it falls under the category. So our management basically will involve three things: lifestyle modification, some physical therapy, then our drugs. So these are the three categories to make it simple: lifestyle modification, our physical therapy, and sometimes occupational therapy, then our drugs. So for lifestyle modification, we would want to first start with our education, creating a good support system for the patient or the child. Because remember, this is something that would happen over and over again. There'll be periods where they can't participate in school activities, in sporting activities and all. So the psychological component of it must be dealt with. They may have missed school days and all. So all stakeholders must be put together to form a good psychological support group, right? Then we look at simple things like the diet. We would recommend whole foods, and there's enough evidence that some of our highly processed and fast foods may be what we call pro-inflammatory, meaning that they have been linked to aggravating or bringing about these symptoms if you already have it. So we would recommend whole foods, healthy foods, and all that, and go easy on our sugars and our highly processed foods and our fast foods and all. And then parents must be very observant in how they observe the daily activities of the child, be in touch with the school teacher if they pick up any conditions, because it's very easy to assume a child is lazy if in the morning they find it difficult to get out of bed, because typically the symptoms present in the morning and it gets better during the day. So you can easily...
Is it because usually in the mornings it is cold?
That could play a role. We don't know that for sure.
Okay.
But we know that long periods of inactivity, right, sort of trigger the symptoms. So typically you have it in the morning because that's after a long night of sleeping, or when you start for a long time, if you like to get up, they may have some symptoms, right? And that's why the second pillar is our physiotherapy or physical therapy, where in addition to seeing a trained physiotherapist who will take you through some modalities to relieve the pain, you would have to live an active lifestyle, right? So when we have your flare-ups, where there's all the pain and everything, yeah, you may slow down and all, but when you're in remission, we encourage full activity. Play your football, ride your bike, play your tennis and all, so that they have a very normal life as much as possible. Then our medications. There are different groups of drugs that we use. Some may have a very heavy toll on the health. Some would require that you visit the doctor on a regular basis, right, to be given the medications either orally or through the vein, right? So
will they be on medication for life or at some point?
So the plan for most primary health care physicians under the directive of a rheumatologist would be to continue the treatment till there's a long period of remission. Then they can look at the science and decide that, all right, let's go easy on the medication, or let's continue because I'm not too comfortable with the duration of your remission. So that's a decision that's made at a point. But we know that once we start treatment early, and if it's effective enough, some children may go into remission, into adulthood, and have no symptoms. And that's good news. So it's something that we hope for. Not every child will have that, but if we start early and give the effective treatment, then we hope that most children would enter adulthood without symptoms and also may not develop any deformities in childhood. Because indeed, there are complications related to the joints, as we mentioned, and there are other complications outside the joints. For example, the eyes may get inflamed, condition we call uveitis, or some may manifest with some skin conditions and all. So we're looking at the joints and the other parts of the body outside the joints. So it's important that we prevent complications in children, right? And also,
if it is not detected early, does it mean that these children may have deformities?
Some may develop deformities based on the severity. And so there are about 7 different categories of the juvenile idiopathic arthritis. Some have a poorer outcome than others. So yes, and so the concept here is early detection by the parent, early reporting, then we start the treatment early. And the treatment will involve more than one thing: lifestyle modification, physiotherapy, and our drugs.
But do you have surgical options for severe arthritis?
Rarely do we intervene with surgery. But in cases where our diagnosis was late, we may need some surgical interventions. But by and large, it's medical management and our other interventions I mentioned.
Yes.
Sometimes children may have deformities. Well, what we usually do is to wait till they reach what we call skeletal maturity, meaning that, all right, they are no longer growing tall, so now let's go and correct the deformities that you acquired as a result of the disease. But then if we can prevent these deformities, then let's do that through our early recognition, early reporting, and our early management.
What is Nuffield's approach towards this early recognition and early management?
Education, education, education. And to let everyone understand that we're all stakeholders: parents, brothers, sisters, teachers. If we're all observant, we can pick up on some subtle changes in children's activities and report early, right? So this is not just for parents, it's for everyone, right? And if we know about it, then we can do something early enough about it. So our first approach is education. Then on and on, we'll look at building the capacity of doctors. Because in Ghana, with a population of about 30 million, we have less than 10 rheumatologists, right? Meaning that there's a lot of work that they have to do. So if they can build the capacity of our first-line doctors in managing, in first diagnosing and managing this, then we can manage it more effectively. So start with education and capacity building, then we'll advocate to make the treatment more accessible and affordable. So that's the Nuffield approach.
Okay, all right. Thank you very much for coming. So that's Commander Dr. J.K. Aggrey-Orleans. He's a trauma and orthopedic surgeon with a Nuffield Clinic. And that's it for Health Alert. When we come back,